Okay, now I see everybody can see my screen right now. So thank you all everybody for joining us today. We are the webinar, The Effect of Stigma on the Prevention and Treatment and Recovery of Substance Use Disorder in Hispanic and Latino communities. Thank you for joining us. We will have a simultaneous translation to Spanish that is available in your screen. You can see an interpretation button in the bottom of your screen and click the interpretation to select the best language that you want to hear the information. Puede presionar la pestaña que está en la parte de abajo de su pantalla para seleccionar el lenguaje que usted entienda, ¿verdad? Y desee escuchar la presentación porque tenemos la interpretación simultánea disponible. During today's sessions, we have, first of all, it's recorded. This webinar is recorded to your reference eventually and will be available in our website. Please make sure that your computer speakers are turned on you and you can hear the presentation very well. Please make sure to maintain your microphone in mute during the presentation, and if you like to ask any question or share your thoughts during the presentation, please raise your hand or keep your questions in the chat to answer those questions in the section of Q&As. You can also address your thoughts in the chat box. And if you have technical issues, please send a message to our chat box. And someone, myself or Pisaida, that she's also with me, Hispanic and Latino Behavioral Health Center of Excellence representatives will answer those questions as well. Please be sure to complete the evaluation at the end of this presentation. It's really important to all the projects and presentations that we do because it's part of our efforts and the impact that we are doing in the community, and it's the evidence for us to continue to doing our work. So basically, after the presentation at the end of the seminar, you will have a QR code and a link both in Spanish and English that you are able to answer the evaluation form. It's pretty short, it's pretty quickly, but that information is really helpful for our organization. Thank you for all that you complete the evaluation. 1 week, or at least 1 week, then you will have a certificate of participation. The Hispanic and Latino Behavioral Health Centers, we have our mission is to advance and support the sustainability of behavioral health by promoting grounded, community-driven, culturally grounded, and person-centered prevention, treatment, multiple pathways of recovery, and recovery support for Hispanic and Latino communities. A brief disclaimer is that the presentation is prepared for the Hispanic and Latino Behavioral Center of Excellence in conjunction with our collaborators and under this cooperative agreement from Substance Use and Mental Health Services Administration, SAMHSA, that is spelled in English. The content is solely and responsibility of authors, but also do not reflect the views of SAMHSA. All materials appearing in the presentation except that taken directly from copyright sources in the public domain and may be reproduced or copied without the permission from SAMHSA or other authors. Citation of this source is appreciated. This presentation is also recorded and will be available in our website. During the presentation, we also be sharing the presentation in the chat box. Prior to go through the learning objectives, I now want to formally thank you and take a moment to express our heartfelt gratitude to Childproof team, Gabriela and Robert, that both of them are here with us as part of this collaboration and for make this possible for all the community. That is a very important topic to discuss. They will be sharing also more information and incredibly important work that they are addressing also and reducing stigma, and which connects directly to today's discussion. For today's webinars, we are very glad again, and we have the honor to welcoming Dr. Hector Colon Rivera, that he is one of our strong collaborators in the center, and we want to acknowledge the importance of this topic and everyone that is joining us today. It's a really conversation that deeply matters very deeply, and we are very grateful to have such a knowledgeable voice leading this topic. Please note that there will be time for questions, as I mentioned earlier. At the end of this presentation and at the end of the webinar, we have enough time to answer those questions. So taking that into this time, I will want to welcome Dr. Hector Colon to begin officially this webinar. Dr. Colon.
Sure. Buenas tardes. Good afternoon. So I'm in Philadelphia. I'm the medical director for APM, which means Asociación Puertorriqueños en Marcha. I also work for SAMHSA, and I work for University of Pittsburgh, doing some telehealth. I'm an addiction, adolescent, sport psychiatrist. So I do a lot of performance. I see athletes and also start seeing kids at the age of 10. So this topic, I mean, it's not super new. I mean, we know stigma still around. But today we're going to talk about how this affects, prevention, treatment, and recovery of substance use disorder in the Hispanic Latino communities. We have a few objectives today, and I'm actually glad that I'm presenting with some colleagues today. So you're going to see and hear a lot about this topic and from different perspectives. So from my perspective and objectives, we'll talk about the mental health and substance disorder trends in the Hispanic and Latino communities. We're going to describe some of the standards, components, and the 3 levels of stigma. We're going to discuss and list some practices for preventing and reducing stigma and evidence-based ways of preventing and reducing stigma, depending where you work, different settings. So I saw that there's some people from different states, including Kansas, Colorado, Puerto Rico. So that's amazing. So what we know about Hispanic population? Well, it's not stopping. It's going up, and I'm not talking only about migrants, but in general, right? The Hispanic populations are increasing. This is only from 2022 to 2060, so it's been increasing. And as you see, the graph goes pretty straight, like a line going up. So in the future, probably 1 out of 5 people are going to be from Hispanic descendancies. So what we know about Hispanics and health outcomes, we have a lot of limitations still. And we have insurance coverage as one of them. In 2022, so probably 2-3 years ago, since we just have way in 2025, about 16%, almost 17% of Hispanic lack health insurances. My practice, I have grants that see people without insurances, also people that are working towards getting insurances, but we have a lot of patients, both from that are legally here versus immigrants versus refugees or looking for asylum that don't have insurance. The mental health access is really hard. Waiting time is amazing. I don't know, probably you guys know more than me. When you call a psychiatrist, you call a behavioral health specialist or professional, the waiting time could be months at times, especially for one that speak the language of that patient. So in 2023, Hispanic adults were 60% less likely to receive mental health treatment than a non-Hispanic wide group. So also we suffer a lot from chronic diseases. Hispanic adults have 50% higher prevalence of concurrent diabetes and peripheral artery disease. We see a lot of heart disease, strokes, and of course, diabetes is though that combination of hypertension and diabetes is pretty prevalent in our communities. TB also accounted for 36% of all reported TB cases in the U.S. So imagine that. So 1 out of 3, almost 1 out of 2 cases of TB were from Hispanic communities. I cannot separate there were migrants or migrants or there were from the States, but that's the data. HIV infection also is a little bit more, is higher in Hispanic populations, especially the incidence of it, the new cases, and dementia is a big one, and it's projected to increase. in the future. When we talk about societal challenges, not only the health challenges, but also what we see in the society, we see the population growth and influence. The Hispanic community reached about 64 million in 2023, making up 20% of the US population. At least in Philadelphia, where I practice, we are 18% of the Philadelphia community. In some counties of Pennsylvania, is almost 51%, 52%. So some counties are completely Hispanic. So Allegheny County, things, places like that, there are completely Hispanic. There's when we talk about the youth, right? The younger part, Latinos are the youngest major ethnic groups in the U.S. as well, with a median age of 30. So usually people in the when they're starting to work, they have a career, or they're starting to have families. So pretty young Hispanic communities. There is a lot of economic contribution to America. It's about 3.2 trillion annual U.S. economy, and we earning about 73 cents for every $1 earned by non-Hispanic whites. In terms of demographic and society challenges, this is just a table resuming in terms of education, language, and the health society impacts. So only 23% of Latino ages 25 plus hold a bachelor degree. So education, that's something we deal with in the community. My patients, we have a high dropout rates here in Philadelphia. Probably that's the same to other urban area with high Hispanic communities or color communities. Roughly 28% of U.S. Latinos are limited English proficiency. So it does impact healthcare navigation, public services, access. I mean, great example is when you guys call Medicare is a big one, right? Older Hispanics with medical issues trying to collaborate with the system. And the system is pretty stigmatizing because it's not prepared for our community. I mean, it takes longer time to get a Hispanic or someone that speaks Spanish for the client. Also, the waiting time is longer for that. And when you go to office, no one speaks Spanish, so that's not great. Also, when you go to the inpatient units, right, there's no staff that speak Spanish, or you go to rehab or even outpatient. It's really hard, and they use the interpreters or translators to try to help. But we know it's not the same. In terms of foreign-born population health in the U.S., we know that the ones that are not raised or born in the U.S. are I was healthier in some ways than the ones that the U.S. born Latinos that actually are born here. And there is a relationship with the acculturation is a big factor, and relocation stress is a big factor. So when I talk to my patients, it's like, well, yes, coming here is pretty stressful, especially if you're not from Puerto Rico, you need to cross the border, or you're here illegally. So that's a big stressor. So usually they get really they get sick at the beginning while they look for a better health, a better being on the system. So this is really interesting in terms of a stigma, right? Because it's really hard for these patients to start and accomplish what they want to do. I mean, it's a long time situation. They need to wait for services and be accommodated in terms of housing, schools, and things like that. So that impact the health, especially those that have no U.S. citizenship. So in the past, we talk about substance use disorder among Hispanic people aged 12 and above. We have alcohol disorder is the big monster, and followed by marijuana. In terms of everything, right? If you combine everything, is about 9.9%, so almost 10%. And this is in the past year, those 12 and older. So yes, kids suffer from substance use disorder, adolescents suffer from substance use disorder, and this is the result. Heroin is not as hot For Hispanic, even though Puerto Ricans, if you compare to other Hispanic populations, have the highest use of heroin and opioids. If you compare directly to Hispanic, but it's not as the prevalence is not as high as white populations in terms of the heroin use. But alcohol is pretty high and marijuana is pretty high. Substance use patterns among Hispanic Latino subgroups, what we see here, there's a lot of Puerto Ricans that suffer from alcohol use disorder, also opioid use disorder, comparing to others, Mexicans as well, but lower rates from illicit drugs like heroin compared to Puerto Ricans. Cubans has a lower rates of recent marijuana and cocaine use, so they use less of the illicit drugs and probably less alcohol. And Central and South American, the lowest rates of illicit drugs among all Hispanic subgroups. So usually Caribbean suffer a little bit more or significantly higher incidence and prevalence of substance use disorder comparing to our friends in other subgroups like Central and South American. In terms of perceived need for substance use disorder, this is good. Nearly all Hispanic people with a substance use disorder, they tend. So take apart alcohol, which is a tricky one because there's a lot of stigma. So let's put the stigma aside. And if we're talking about illicit drugs, yes, we have a really hard time accepting that we have a problem. Alcohol also because is acceptable in society. So almost all people that actually suffer from substance disorder, they have a hard time accepting treatment because of the stigma. And I mean, we know about in the Hispanic.
Okay. The third column is now with us again. Thank you, everybody, for.
Sorry about that.
No worries. I just explained everybody that you actually lost the power in your location and you have.
That never happened before. So
No worries. So,
sorry about that.
meantime, we talk about the locations and present themselves. So you can go ahead and continue your webinar.
Okay. Sorry. So we were talking about the mismatch
Yeah.
between the services and our population. Let me go back to the presentation here. Beautiful. And sorry about that. Talking about stigma and electricity goes down. Okay. So Latino, yes, and the mismatch between the need for services and the utilization of this. So for example, I mean, the graphs that we see in the past year, we see how any mental health 18 plus, we see like any treatment versus not treatment. So any treatment means could be as easy as probably calling 988 or showing up to the urgent care. So we see that only 1 out of 3 people use it for any mental health. It could be depression, anxiety. When we go to major depressive disorder, which are more severe and a more standard diagnosis, we see that the utilization is less. In terms of serious mental illness, we have a little bit more power there. They're more significant. People see that, witness that. So usually they use the police, they call ambulance. So we use the utilization is more, which in theory, I mean, Hispanics are higher users of emergency departments. I mean, we don't usually follow with outpatient providers, our PCPs, our psychiatrists, but we do go to the urgent cares and emergency rooms. You can see in how the difference between mental health and substance use disorder, which in my mind, I think it is in the data, it shows how stigmatized mental health is, but how more stigmatized is substance use disorders. Okay, and there's some states, and you can put examples on the chat what states you work at. But some states they divide mental health into budgets. So we have substance use disorder in one budget versus mental health in a different budget. In some states, they merge, and you have more of these called uh, co-treatments and dual diagnosis facilities. In some states, that's not even a opportunity. So what is stigma? I mean, we talk about this. We mentioned this word as it was not tomorrow. Stigma is a mark of disgrace, which is associated with particular circumstances, quality, or people. We all have some kind of bias on us. Some people have more bias than others. I think there's a lot more bias than 10 years ago, which is with the opposite, which would be progressing, now regressing, but we see a lot of bias in the society. It is a barrier to receiving healthcare and engaging in help-seeking behaviors. Also, it results in discrimination and exclusions, usually from marginalized groups. Why talk about stigma now in 2025? I mean, just go outside and you can live it. It's a rising problematics and substance use disorder rates, even though we are seeing a decrease overdoses, right? But the substance use is still up. Overdoses are still happening, even with the help. Now we are, I guess, the new government at White House is limiting access to data, so we don't really know what's going on. But in theory, has been decreased a little bit in terms of overdoses. There's an ongoing workforce burnout. This is the workforce that worked through COVID-19 and are still recovering from those time. So it's a lot of burnout, especially for people that work in these settings, right, with mental health patients. There is a new data from HR Proof, and we will hear more about that. I'm pretty excited about that, which they call it the SASI. So, and it's correlated with national surveys. So high impact areas for intervention, emergency departments is a great area to start interventions there. Of course, primary care, mental health offices, and any type of behavioral health clinics. They're full of stigma in terms of, the pressure from society versus the internal stigma. A stigma is dynamic, it changes, it's multi-dimensional. That's why I say 10 years ago, it was probably still there. It was a hot topic. Now it's back to being a hot topic. All the changes are happening super fast. It's a phenomenon, and it can be divided in three levels. So we have the societal, the public stigma. The society, what I mean, the structure was everything is placed and is supposed to be working at. So we have the public stigma, so that's the eye of the people, and we have how we see ourselves. And the structure, of course, includes the laws, the regulation, the policy. So everything that runs society versus the public is the belief of those people that live there. And of course, our internalized negative stereotypes. And I'm talking about self-esteem, right? That's a different topic. We're talking about how you see yourself in terms of, in terms of how you feel about your abilities and things like that you present to society. Stigma in three levels. So again, the state health agencies are part of the structural stigma. Those are the people that make the decisions, and if there's a lot of bias up there, there's going to be a lot of changes, pressure already marginalized populations. And in neighborhoods, in terms of public stigma, there are a lot of perspective regarding the presence of drug activity, education, and education, drugs, and probably home and housing is there are the three main ones. And self-esteem, believing that you're not worth treatment or not thinking about treatment, as we saw in the other graph, that only probably 2% of Hispanics that they have the substance use disorder to look for treatment. Commonly studied dimensions of stigma. I mean, we had the blame, individual are to blame, control, and fault. Remember, the stigma of especially substance use disorder has a lot of and still have, even though we are calling it a biological disease, still have a lot of morale. You chose to be a substance user or a person with problems using drugs. Some people see it as a choice and not as a disease, even though genetic is part of it and trauma is part of it. I mean, there's a lot of components, not only you choosing or will, right? The social distance will have then marry into a family. So it's like the common dimension of stigma is that societal part, that family part, that if you are not part of that society, you cannot be part of you're part of this one, you cannot be part of the other problem. So if you have a substance disorder, probably you should not marry a good family. So that's just a few of the stigmas that we see in our society, and the dangerous of it. If you are a substance user or you use substances, and a person with a problematic use of substances, you're not safe. You would not be safe. You probably should not have kids or a wife or a partner. Um, Stigma across the continuum of care. So this is the maintenance. So drugs during active use, right? Also seeking treatment and the long-term recovery. So even when you're stopping, even when you're stopped forever and you've been sober for 15, 30 years, the substance use disorder part of you still with you. When you talk to people, when you talk to your family, your brothers, your sisters, you will be that person for them. That's a huge stigma that's across the continuum of care. Some people relapse because of this. Some people never feel worth it. There's a lot of intersection, but with people with problem substance use, stigma in terms of race, gender, housing, status, criminal justice involvement. Most of the patients we see are coming because they are part of uh, the legal system. Also, we see more of the Black and Latino individuals on this system as well. There's a lot of treatment disparities. Racially diverse population often face more barriers on the quality and even medications that are available to them. Criminal justice involvement, formerly incarcerated individuals often face the stigma. And the problem with this is that not being a criminal is how you integrate back to society. And that's the big part of the stigma that we see, getting back to society after you've been stamped with being a criminal. If you're a criminal with substance use disorder, you have double stigma on your belt. There is a lot of mandatory treatment programs, which in theory, some of them work depending on the probation officers you have and support of the family you have. They help and depending where you live too. So they can provide you with access to care. And that kind of structure helps a lot of people. In terms of engagement and outcomes, stigma can reduce adherence to care. It can higher dropout rates when you are in treatment. It can delay treatment as well. And also avoidance to preventive health services. I mean, is a big sample is knowing you have HIV and accepting you have HIV and going to HIV clinic because of the stigma that kind of disease has or that condition has still in society is a big one. Even though people live long with the disease now, and there's no physical differences that separate you from them. There's a lot of the descriptive levels. I mean, substance abusers, substance use disorders. So they see it as punisher, right? Punishment. So it's easily more acceptable to be a substance use disorder or having a substance disorder than being a substance abuser. So that's what this is. I mean, and of course, substance abuser feels like it is more blaming, more self, versus when you talk about a person with a substance disorder, they feel that they're more acceptable. So words matter. What work structure stigma? There is a lot of advocacy, legal, policy, education that we can do. This is what we're doing today. in terms of self-stigma, a lot of empowerment, looking for peer support. Having peer supports on your clinic is amazing. I mean, people that went through the same and can talk about their experiences. I love group therapy. I love having a one-on-ones too. It's about breaking the cycle. I mean, it's kind of long, but stigma remains a pretty major barrier for people, especially people with mental health and substance use disorders. So anything you guys do for your patient, it helps. Remember, words matter, and the ways you express your facial expressions, they do matter. And of course, we know the problem is there, but recognizing the problem is not enough. So we should shift the narrative to help our patients. So with this, I would love to have our colleagues from Shatterproof to talk to us. Thank you, guys.
Thank you, Dr. Colon, for that impressive information. I will stop sharing my screen to introduce Gabriela Granata, and she is presenting her screen.
Awesome. Thank you so much. We're really excited to be here from Shatterproof, and we'll be talking about stigma in healthcare and an initiative that we've created called Provider's Pathway to support patients with substance use disorder. We like to start all of our presentations just with setting an intention. Some of these conversations can be really difficult. In a bit, we're also going to go into an activity where we're going to ask you to share some of your thoughts and to be interactive. So just a reminder to keep an open mind, and we're all here to help support those with substance use disorder and those affected by it. And that's what we're going to do today. So again, we're really excited to be here. When I say we, I'm talking about Shatterproof. Shatterproof is a national nonprofit organization that's dedicated to reversing the addiction crisis in the United States. Within that organization, we have a very big emphasis on stigma. And then within our stigma team, which is about 20 people large, we have a healthcare team that's dedicated to specifically looking at healthcare stigma and thinking through ways that we can address it. So I myself and my two colleagues, one who's also on the call and will be monitoring the chat box in case you have any questions, are here today. And yeah, again, one more time, but really, really excited to be here and for this partnership and to share more with you. So some learning objectives for our part of the presentation include understanding the impact of stigma in the healthcare setting. We're also going to talk about how stigma affects patients with substance use disorder, and then exploring evidence-based strategies to reduce stigma, and that will include our intervention, which is a provider's pathway. So just to give a little bit of context and background, in 2020, Shatterproof launched a national movement to end addiction-related stigma. And then in 2022, we received, our healthcare team specifically, a $5.4 million grant from the Elevance Health Foundation, who works to support nonprofits that share its mission around improving lives and communities. And we used that grant to further the idea and create Provider's Pathway. So we were tasked with designing, implementing, and evaluating a scalable SUD stigma reduction intervention specifically for healthcare providers so that they can assist their patients who have substance use disorder. And there were focuses on health equity and intersectional stigma as well. As was mentioned briefly, something that Shatterproof created a few years ago now to help us understand stigma in the field was the Shatterproof Addiction Stigma Index. So we're going to talk about that a bit, and then that's going to lead us into our interactive element, which we would love for you to participate in. We've already kind of talked about a background on stigma and what it is, but again, a really important topic because it is associated with barriers to receiving healthcare and engaging in help-seeking behaviors. So that, again, was the inspiration behind the Addiction Stigma Index. It was created in partnership with researchers at Indiana University and the global marketing firm Ipsos. And Shatterproof developed and released the SASI, which is what we call it for short. And it is a first of its kind measurement tool that assesses attitudes about substance use and people who use substances. And we're getting that information from the public. We're trying to understand their perceptions. It also measures the perceptions of those with substance use disorder, including the degree to which they have internalized this exclusion and this stigma and this shame that we're talking about. It utilizes indices. It has 3 different stigma indices that measure public, structural, and stigma, which we've already gone over. And then it also utilizes a vignette strategy. So to engage a little bit further in what the SASE does and to promote some collaboration, we're going to do a quick exercise. We've taken 4 of the questions from our SASE and loaded them up onto what is called Menti. There is a QR code that you can use to scan to get access to this interactive activity. My colleague Robert is also going to put in the chat this link, and there's an access code that can get you onto the right page. So I'm going to give you all a minute to access that. And it's really just a polling system. So I'll ask you these 4 questions. Each one will be individual. So you'll get the first question. We're going to look at live results. So your names are not associated with this, but we'll get an idea of anyone who's participating and what they feel about these questions. And then that'll be an opportunity for anyone who wants to share some thoughts on why they answered how they did. And then we'll show you the results that we got on those questions when we had released the SASE and what the public was saying. So we'll give it a few minutes. I'm going to pull up my screen to make sure everything's working properly. Yes, so the link was just added. Seeing Pearl's note here, I can copy it and try one more time. I see. It seems like we might be having a problem where our chat is only going to the hosts and the panelists. Let's see if there's a way I can fix that. Oh, thank you so much for posting that for everyone, Esther. Awesome. It seems like we're getting some people in, which is great. And we'll give it a few more minutes. Oops. Okay. So while people are logging on, I'm going to jump to our first question so you can see that. And that would be, how willing would you be to have someone with substance use disorder as your coworker? So if you're in that Menti page, you should see this question and you have an option to say definitely/probably willing or definitely/probably unwilling. I'll give people a few minutes to answer that and then we'll look at the results in just a second. Seems like we have about 56 people in, which is really great. Thank you all for participating. We really appreciate it. And then while we're getting a few more of those answers to roll in, just a heads up, I'm going to ask for people to share a little bit more on their thoughts if anyone's willing in just a moment when we look at these results. Okay, I'm going to give it about another 10 seconds. Okay, awesome. Thank you again, everyone, for participating. Whoops. So from this audience, how willing would you be to have someone with substance use disorder as your coworker? We had about 87% of people say definitely or probably willing, and about 13% of people say definitely or probably unwilling. If you are willing to share in the chat or want to raise your hand and to speak a little bit more about why you thought this, we'd love to hear it. Again, we understand that everyone has different reasons and expectations around their answers. We're all here really in support of learning and growing, but would love to hear from anyone in the audience if they'd like to share. We did have someone in the chat make the comment that it depends on the substance. In our vignette strategy that we have shared, we do specify a story about a man named John. We talk about a specific substance, and there's a couple different vignette options. So we go through a bunch of different situations, whether that person is in recovery or active use, what the substance is, how they originally came in contact with that substance. So those are things we go into a little bit more. Yep, so we have another comment. Having a substance use disorder doesn't mean that person is actively using. Absolutely correct. Someone else noting it can be a positive step for an employee and an employer. I think absolutely. Something we really promote at Chatterproof and agree with. I have a substance use disorder clinical practice. They have to have a certain amount of time absent. They cannot be in active use for safety reasons. That's definitely something that makes sense. We've talked with a few organizations about their policies, and those are things we've explored as well. They can be great advocates and peers, absolutely. We do have a question that says, how would an employer know? So we know that these questions are a little intentionally vague. There's, again, a little bit more information with that vignette strategy when we put this out in the field. But yeah, valid question. And lived experience is beneficial to help others, absolutely. So again, we're looking at about 86% saying definitely or probably willing. I'm going to show you now what, oh, sorry, one more question. And I love this comment. I have unwittingly worked with so many people who have a substance use disorder, and I only found out once I got to know them. I haven't noticed it impacting their work performance or their relationships. Such a valid point. A lot of times we don't know, and most of the time we are engaging with people who either have or have been affected by substance use disorder. All the time. So such a great point. When we fielded this, our results showed that about 77% of people were somewhat willing to work with a person who had substance use disorder as their coworker, or 23% were somewhat not or not willing. So we're seeing about a 10% difference there in that first question. Next, we're going to go to our second question. This should be live for you as well now in your app. How willing would you be to have someone with a substance use disorder start working closely with you on a job? Willing until it begins to affect the job. And again, these questions are intentionally vague, so that's a point that we've had brought up before. Didn't come through. Okay, let's see. Maybe, here we go. Okay, there we go. Awesome, we'll see those rolling in now. Awesome. Thank you all for your participation and your comments. They're really appreciated. I'm looking back through to see if I missed anything. Someone noted that it creates unique strengths and perspectives. That's also something that's really important. Seems like maybe there's a couple people that says they've already answered, but not a problem. Thank you for letting us know. Absolutely important to have people with lived experience and people with all different backgrounds and experiences on a team, especially when we're talking about stigma and substance use disorder. Depends on the type of job. Okay, it looks like we have about 36 people who have answered, so I'm going to give it just one more minute to make sure everyone has a chance to participate. I'm really intrigued by this response just because we have more people saying definitely willing so far than we did on the first question. So I know we're missing a few people, but if there's anyone who switched their answer and wants to comment in the chat, I think that's just like really fascinating. But yeah, we're doing great. We're getting a couple more coming in. If anyone again wants to put any comments in the chat, it looks like we're at about a similar percentage now to where we were on that first question. Yeah, some people can be functioning. Yep, again, that comment about we might be working with people who have substance use disorder and not know it, that's extremely valid. Just by definition of having a substance use disorder doesn't necessarily mean that'll impact your job or your job performance. They can be extremely reliable and dedicated employees because they know the hands of the reality of substance use disorder and I can advocate for that community. Absolutely. Are these questions specific to recovery support spaces or community in general? When we fielded this was just asking the community in general. We did later break things down a bit more. We have data specifically on providers that we'll talk about in a moment, but these results were general. We're including a willingness to change, again, not captured in these questions, so that makes sense. All right, so it looks like everyone has answered, and so we're about a percentage point or two with more people saying they'd be definitely willing, which I think is really interesting, because now we've added in this component of not only are they a colleague, but you're working very closely with them on the job. When we shared out this survey and we got the results back, we found that less people were likely to answer favorably on this question. So we're looking at about 52% saying somewhat willing or willing, and 48% saying somewhat not willing, somewhat not or not willing. And that addition of the term closely changed that response. How do we remove this from the hiring process or sneaking this into the hiring process? I don't know if you mean how they would know. Some people do willingly disclose. But okay, great that these responses stayed consistent from this group, and it's great to see that the idea of working closely isn't something that people are affected by. Our third question is, how willing would you be to hire someone with substance use disorder do work for you? The group can be biased. I do find that when we give these presentations to other people who are in the space, it's always a little bit validating and reaffirming, so a very good call out. Yes, Robert, if you are able to someone asked if we have a working or operational different definition of substance use disorder. We can talk a little bit about what ours at Shatterproof is, and we can share that for sure. It looks like everyone has access to this question, which is great. Okay, so he didn't come through again. Hopefully perfect. Awesome. Okay, we have about 37 people who've responded so far. So for this question, hopefully it's the one that you're seeing. We're now asking if you are the person hiring them. Sorry, it seems like we're getting some people where it says they've already answered as well. I do apologize, but very open to having you share your thoughts with us if you'd like. Okay, I'll give it about 10 more seconds for a few more people to respond. We have about 45 so far. And again, thank you so much for your participation. Okay, if anyone wants to throw their thoughts into the chat, you've all been so interactive. It's really, really appreciative. This question now obviously has the layer of not only is it someone working with you or working closely with you, but you'd be the one hiring them. So they'd report to you. In most jobs, that would kind of mean their job performance. Your job performance can be dependent on their job performance. That's that extra layer that this question is getting at. Yep, we're talking about someone being able to, one, right, just because someone has a substance use disorder doesn't mean it would affect their job. A substance use doesn't necessarily mean somebody's actively using, absolutely. And again, these questions are designed to really test stigma from the public. And see, you know, just reading that, give somebody a reaction. Are they willing to think through some of those scenarios, which maybe would lead towards that probably part as opposed to definitely on either side. But it looks like we've got all our responses. So again, still pretty consistent. We're at 83% of the group saying definitely or probably willing, slightly lower than that last question, but not by much. Whereas when we fielded this, we now have the majority of people saying somewhat not or not willing, while we had 46% of people saying somewhat willing or unwilling. We do have a question where it says, I'm struggling to see how a person's disability and making a hiring decision is not a violation of the law. Valid comment, although, right, we do know that it happens. These questions were more designed to ask random people from the public what they would think if they had the information and were being asked to make this decision. So it was more about looking at their levels of stigma and their feelings around what this question evoked for them, as opposed to people actually in this position and what they would do, if that makes sense. Working in overdose prevention and peer support is a must with a lot of communities, absolutely. If it was not person-centered or anti-stigma language was asking the question, yep, the person who's asking, the language that's used, all of those things absolutely affect stigma. Yep, using stigmatizing language when you're asking that question, absolutely. We've seen even just in, we'll talk about healthcare more specifically in a minute, but using stigmatizing language in a chart can lead to more stigma towards patients. It can be an asset, absolutely. Okay, we're going to go on to our last question. How willing would you be to have someone with substance use disorder as your supervisor at work? So I'm going to start this. You should now all have access to this question. And we're seeing some answers come in. Amazing. Thank you again. It's really none of my business unless I'm specifically looking for someone. We also got a comment, our agency encourages companies to hire people in recovery. So different than hiring someone who came from the criminal justice system. Everyone deserves a chance. Absolutely. I strongly agree with that sentiment. And again, someone saying, it really depends. There are risks or there could be safety concerns. Again, questions are designed to be a bit vague, so I know it can be really frustrating when answering them and having more follow-up questions. Okay, we have about 30 people so far on this question. And again, it's how willing would you be to have someone with substance use disorder as your supervisor at work? Yep, definitely acknowledging that we're maybe leaning a little bit more positively here in this group, which, while validating to see is important to call out. We've done this exercise with different groups across with different groups across different backgrounds, employment experience with working with people with substance use disorder, and we've definitely seen the answers vary based on where those groups come from. Oh, so sorry to hear that. Thank you so much for being here, though, and for your participation. Can provide valuable insight. Yeah, if you have, I don't know if I said it already for this question, but if you have thoughts on this one specifically, please include them in the chat. We have about 35 people who've responded so far, so I'll give it another minute or so. I do believe a copy of the slides will be going out. Because we are a prevention agency, we would not be able to hire anyone with present or past addiction. Yeah, this is also something at Shatterproof that we've talked about specifically around employment and working with groups and looking at their hiring practices and things. And some people, it is unfortunately currently not something where they're able to partake in certain jobs. Okay, we have about 36 people. I'll give it about 10 more seconds, but we're looking at 75% of people here saying definitely are probably willing to have someone with substance use disorder as their supervisor at work. So again, we're seeing that decrease right now. Not only are you working closely with them, but they're directly going to be impacting your work experience and things like that. So we're seeing a bit of a decrease here. When we fielded this, we saw that 68% said somewhat not or not willing, and 32% said somewhat willing. So with each of these questions, we're really removing that social distance around someone with a substance use disorder and increasing the ability for the person that we're talking about to be able to impact, at least specifically here, employment and your life at work. So yeah, as we've gone, it's been pretty consistent that we've seen decreases in willingness. Okay. Feel free to continue asking some questions in the chat, but I'm going to continue on to talk a bit more about healthcare professionals and substance use disorder stigma. So again, looking at some SASI data, 45% of healthcare professionals falsely believed that substance use disorder was caused by a person's own bad character, or really that idea that it's a moral failing. Again, when we did the SASI, we did over consider healthcare professionals to try to get a gauge of what specifically they might be thinking and be able to compare that to the public. So that's where these numbers are coming from. We had 69% of healthcare professionals say that they would be unwilling to have someone with substance use disorder marry into their family, and 50% would be unwilling to have a person with substance use disorder as a close friend. Again, given stigma, we probably have a lot more people around us than we think who are experiencing, or rather who have substance use disorder. But this is, again, looking specifically at healthcare providers. And then lastly, 61% of healthcare professionals endorsed the idea that medications for opioid use disorder, or MAT, was substituting one drug for another. And these were just some of the data points that we pulled that really showed us how important it was to focus specifically on healthcare providers in order to impact the outcomes or health outcomes for patients and people with substance use disorders. So we'll go a bit more specifically, given that, into stigma in healthcare. So when we're looking at the issue, again, stigma towards people with addiction can lead to discrimination, social isolation, and a lack of social support. And it can affect not only their daily lives, but their ability to seek care. The SASI data shows that healthcare professionals do hold relatively high levels of addiction-related public stigma. And it is a layered issue, right? So we have burnout, especially coming after COVID. We know that a lot of providers, people are short-staffed. They are maybe not given the tools to succeed as much as they would like. We also have stigma as a huge layer here. And as a result of that, only 14% of people with substance use disorder tend to receive the care that they need, which is a very small number. Reducing stigma held by the healthcare professionals could help millions receive quality healthcare when they need it, and it could also open up more pathways to treatment and recovery for those who want it. Again, emphasizing that autonomy piece as well, and we want to be mindful to consider people and their wants and their needs. Yeah, so definitely an issue when we're talking about stigma in healthcare settings specifically. And in addition to that, we also have this issue around health access to people for substance use disorder care and their health outcomes. While anyone with a substance use disorder is likely to face stigma in any setting, but specifically in the healthcare setting, people who hold multiple stigmatized identities are going to face additional stigma, and that stigma can often be compounded. And this is what we call intersectional stigma, which we have talked a bit about already, but health challenges can really be influenced by this topic. So research shows people with multiple stigmatized identities experience additional bias, discrimination, and injustice when they are interacting with our healthcare system. And thinking of all of these things, and in an effort to address this, Shatterproof has applied data-driven approaches. We created a provider's pathway, and we also identified a subpopulation for this program when we did it, which was our focus on the Latino population, which is why we've been able to create this partnership and present here today. So again, a little bit more on the why. Stigma among healthcare providers is driven by many factors, including inadequate training, lack of education. Even if they do have the education, sometimes they don't have the support or the means to act on it. There are systemic barriers, and there's also biases involved. So improvements across some or all of these drivers ideally would lead to improved quality of care for all people, including those from marginalized communities. And absolutely, some people lack empathy, as someone just noted in the chat. So now, taking all this information, I'm going to share a bit more about our specific opportunity, which is called a provider's pathway. We saw this as one solution to many that are needed on all the different levels that we're talking about here. But a provider's pathway, again, one solution to address stigma towards patients with substance use disorder in the healthcare system. When we created this initiative, while Robert, myself, and Megan, who I showed our lovely pictures of on the slide earlier, are the healthcare team at Shatterproof, we worked with scholars who provided research and directed us in identifying a program audience and beneficiaries. We also had a layer of support from an external advisory board. Those people were made up of providers themselves, people in the community, scholars in mental health and health equity, and as well as people with lived experience. So it was really important for us to make sure, as we've been seeing in the chat, that everyone had a seat at the table and we were getting diverse perspectives in creating this intervention. And we've also worked with the Yale program in addiction medicine. So our approach, we are doing this pilot intervention. It's called a Provider's Pathway to Supporting Patients with Substance Use Disorders. It is an asynchronous e-learning curriculum. It is customizable and flexible, and it's had 3 initial releases so far. There is a general component to this training. There are 5 modules that talk about stigma towards people with substance use disorder generally. And then there's an additional 2 modules that specifically talk about how Latino patients are affected by all of that information. And we've been able to design it this way so it's scalable if effective, where we would keep those 5 main modules and we could add additional ones in the future to talk about different topics or different populations of people. For the work we are currently doing, we are aiming to recruit 3,000 providing prescribers. This includes MDs, DOs, PAs, NPs, and APRNs. And it's been approved by ASAM, the American Society of Addiction Medicine, for 5 to 8 free CEUs, depending on how many of those modules you'd be completing and if you do those extra 2. And in this, we hope to benefit people with substance use disorders, those who are using drugs, and from those communities generally, but also specifically our Latino communities within that group, and the providers who are caring for them. So if you'd like more information, if you're a provider yourself, or you think that this would be something really helpful to share with those in your network, you can email myself or my colleague Robert. I'll put our emails in the chat once I'm finished. There's also this QR code here on the screen. We've created a landing page specifically for a provider's pathway. And we can put that link in the chat as well. It provides information on what is in the curriculum, more specifically, how you can get involved. There's blog posts, and as we start to get that research in, we will probably be adding some dissemination components as well. So I know now we're over to the Q&A, but just want to say thank you so much for everyone, especially participating, sharing your thoughts. I know it can be really vulnerable, but this community seems really wonderful. And so just want to thank you for having us. And if you have any questions, we'd be happy to answer them.
Thank you so much, Gabriela, for that impressive information as well, and all the massive participation of the audience in this part. Thank you a lot. So let's see if we have some questions in the chat to answer any. Meantime, we are sharing our link for the evaluation. But everybody has the opportunity to complete the evaluation. We have both links available in Spanish, but also in English. So please, if you have a couple of minutes to complete the evaluation form, you can use the one that is available in Spanish or in English. Yes, Mariluz, we will be sending the presentation after the event. Gabriela, you're still sharing your screen. Can you put the slide of the QR code, please?
Yes, absolutely.
I believe that's the next one.
Yep.
Yes, that one. Thank you so much. For those that has the cell phone, can scan the QR code that is in the screen. It's also easier to get directly to the evaluation form. and complete the ones. Remember that it's really important for us to complete the evaluation, that it's the evidence and the information, important information that we use to continue doing our work and have a presentation of eventually in this topic and any other topic that we are coordinating eventually. So it's really important. We don't have, let me see in the chat if we have any other question here. I don't see any. Okay, we have a question of Evelio Scamilla. We usually focus on client stigma. We need to see how we project services and settings that are not welcoming to community members, family, youth, elders. How do we address this? I don't know if the question is for Dr. Colon or Gabriela, but I don't know. Probably if you want to answer Gabriela or Dr. Colon, it's perfectly fine.
Dr. Colon, I think you might be able to answer a bit more from your working experience. This is definitely something we talk about at Shatterproof. And while at the moment our healthcare team doesn't have an intervention specifically designed to address that, is absolutely something that we think about. And as we're in talks for continuing to evaluate what other projects we would take on, this is definitely something that we think about.
So I'm not following the question though. What does it refer to the projects? So
yeah,
clients,
Evelio, yes, that one.
our services are very. Oh, got it. Okay. Well, I think part of treatment, for example, I think we always or we should include family, schools, and any person that will be in contact with that. I mean, we're talking about adolescent or adult. I think they should be part of the plan, the treatment plan. I think that will also educate the family, and the family, of course, is part of the community and society. In terms of how we make projects to the community, I mean, for example, we are a nonprofit. We have grants. We have different departments, including foster homes, education centers. We have housing department. So we really try, even those are different departments, we really try to do activities together and in ways of sharing what we do so the community knows. I know in the past, I used to work with methadone clinics, right? I used to have like 10,000 patients in methadone when I was in Connecticut. And it was really hard for the community to accept to have a methadone clinic close to them. So that idea, we needed to start really early and kind of go slowly on how to, share what methadone was, what it does for people, a little bit of education about what drugs are. I mean, it's different between drugs that are prescribers and not prescribed versus something like methadone that's dispensed. So it requires a lot of education. So I agree with you. We don't spend too much time on that. We also don't have a lot of preventative projects. We usually target treatment more than prevention, and that's something we should work more. And I will include that we should work in community, but that also includes nonprofits, includes privates, includes insurances, includes the churches, includes all of them. So if you don't estimate or underestimate part of the community that should be part of the conversation.
And I will also add, thank you for clarifying a bit more to your question. In the 2 modules we have in our intervention that specifically talk about the Latino community, we do cover that in ways in which it is important to consider the community that you're working with. We go through a case study throughout those modules where we're talking with a Latino woman who is experiencing substance use disorder and how she's interacting with her providers in ways in which her needs are not being met. So that is something that we cover in our project as well.
Thank you so much. We have another question from Dan. How do we turn on the internal stigma with our Hispanic members? It is hard to get them because of fears in the community. I believe that the question is aligned with identify some strategy to catch, I don't know, Hispanic members internally in the organization. Then I don't know, probably you can clarify your question. Yes, absolutely. Okay, I believe that this question is for Dr. Colon as well.
So Hispanic members in our programs, so you're saying the fear in the community? I mean, so the internal members are scared of working with the community. That's what you're saying, and how we try to fix that. You say, can we talk? We can talk. You mean like off? Yeah, we can talk. We can talk. So I mean, the fear is always there. I mean, in the past, I know, Gabriela, I mean, you mentioned that I used to be part of, a long time ago, of this community-based participatory research. I don't know how often they do that, or they do it anymore, but it was pretty hard back then when we dealing with Hep C and HIV, and what we did is do the research in a community with community leaders too. So it's really important to include the community leaders. I mean, they know their neighbors. They know who goes to church, who doesn't go to church, where the patients are, who's not a patient, who doesn't use. So it's really important to include those leaders, include the community to understand, and instead of just inviting them to do research with them. I mean, that could help to decrease the stigma. The stigma is always going to be there. I mean, we need to work with our bias too. And there is a lot of microaggressions in our communities as well that we need to be at least aware of them. The problem is that we're not aware.
Yeah, absolutely agree. I think Shatterproof and our team specifically try to be really mindful of what spaces we're entering and who we are talking with and how our backgrounds align, and making sure that we have the right people at the table for different conversations in different communities. But keeping that in mind, that is something that we have covered a little bit in the curriculum. And as we have branched out in our work, have tried to really build those partnerships so that we are leveraging connections that already exist when we're talking about decreasing stigma, because that's going to be different for every community and any group that might be facing those intersectional pieces of stigma as well.
Absolutely. And Elizabeth is sharing that we need to more bilingual providers and educate more in terms of breaking stigmatization. You're right. We have other question from Patrick. What tactics and advice can you offer when encountering individuals or communities who argue that alcohol use is normalized and or not seen as a significant issue? We have another question, but we can go through this first one.
I can speak a little bit to Shatterproof. I definitely not our belief, but when we've done some of the research, and like I mentioned, our SASE has a vignette. So we do look at all the different types, or a few different types of substances, different types of ways a person is interacting with substance use disorder. Are they actively using? Are they in recovery? And how did they first get introduced to that substance? So while we don't necessarily have any strategies at the moment, it is something that we made sure to collect the data on. And we definitely saw differences in responses and stigmatizing attitudes depending on the substance. While stigma is still very high for people in recovery, we did see it a little bit higher for people in active use. And again, also how they ended up being introduced to that substance. So again, no official interventions yet, but is something that we have collected the data on and have seen as being an issue.
Yeah, and it's really hard, right? Because especially in Hispanic communities, Hispanic countries, I would say, we start drinking pretty early in life, and it's more acceptable, it's socially acceptable. But I think it's because we call it alcohol, right? If we reframe that to alcohol is a drug, and we start talking about alcohol as a drug, so using a clearer language, using data without shame. I mean, we can talk about, hey, you're drinking a lot. So do you know that 1 out of 10 deaths in the United States are due to alcohol drinking or this drug use? Also, you can, instead of using alcohol, you can use, this is a pretty sedative medication or sedative drug or central nervous system depressant. And I would do that understanding the cultural context too of that person. And remember, drug use are a spectrum. So drinking is not a substance use disorder. I mean, it's when you have the criteria for a substance disorder, right? Drinking more, I mean, for over 12 months and having whatever urges and cravings and having withdrawal, some intolerance, and stopping, your societal responsibilities. I mean, that's a drug use. That's a substance use disorder. I mean, but people start experimenting, then they start abusing them, and that's where the prevention comes in. So again, I think if we're normalizing alcohol, we also need to normalize talking about the issues that drug, alcohol, could have in you and your family.
Absolutely. We have other comments here related to the information that both of you, Gabriela and Dr. Colon, is sharing. Elizabeth says the misuse or not we need to know the difference between when it's too much. Many of organizations located in Florida, Dan is mentioning that they do not have Spanish speaking staff. That's something that is happening in other organizations as well. And organizations like us, that Hispanic and Latino Behavioral Health Center of Excellence, we are continue working with providing all the information both in Spanish and in English, because it's important for us as well to provide the language access. And meantime, sometimes staff that not necessarily is Spanish speaking then could have the information available to provide to the community as well. So that we are like including different strategies to address those gaps in the way that we can. I don't have any other question in the chat box. I don't know if anybody wants to share anything else.
In terms of things that you can use, I mean, I work for the American Psychiatry Association, and we have a new website, lasaludmental.org. And it's the first tool from the APA after 150 years that is in a language different than English. And it has a pretty good information, interactive information about alcohol use or all the drugs, also mental illnesses. So I think it's a good tool for your patients. And if you want more information about that, I think the EPA can send you like QR codes and flyers and things like that, and we can send it to your clinics. We're also looking for partners. So if you want to partner with me and the EPA, you're welcome. Please email me, because we are always looking for content and people to read our content as well, to give us feedback. I mean, we're trying to be not only cultural, humble, and not only translating information. We need to be really, really in tune in, the website. So is good for all type of Hispanics, right? Not only Puerto Ricans, not only Cuban. I'm biased. I'm Puerto Rican, and so what I see probably is not what you see. So I this is an invitation for collaboration. So thank you.
Absolutely, and I agree with you, Dr. Gona. Well, one more time, thank you so much, everybody. Thank you, Dr. Colon, for being here and share all the information as well. Shari Proof, Gabriela, Robert, thank you very much for sharing the important information. All the documents, the presentation and the video will be available also in our website. Please leave us your important information in the evaluation form. It's shared in the chat box, but also it's projected in the screen, the QR code to complete the evaluation for those that do not do so. Thank you so much for everybody joining us. Let's complete or finish the webinar. Everybody, see you in the next time. In a week, you will receive the certificate of participations. So far, thank you so much, everybody. See you in the next.